Hypomagnesemia can cause a variety of central nervous system and peripheral nervous system disorders. Hence, it is appropriate to call this as a chameleon in neurology. Unlike other electrolytes, this is not routinely checked. Hence, it is easily missed or misdiagnosed as other chemicals. Magnesium plays an important role in many biochemical and physiological processes, especially in the brain, cardiac muscle, and the skeletal muscle. It is involved in more than 600 enzymatic reactions, especially with energy metabolism, protein synthesis, stabilizing vascular endothelium, regulating neurotransmitter functions, ATP, and it also acts as a calcium antagonist. That is why hypomagnesemia can cause a myriad of clinical manifestations. Magnesium homeostasis is strictly regulated by uptake in the small intestine and the large intestine, and excretion in the kidney, especially the loop of Henle and the distal convoluted tubule. It can mimic various central and peripheral nervous system diseases, and it is easily mistaken for autoimmune or paraneoplastic disorders. Despite its importance, it is not routinely checked, hence it is easily missed. So how is it misdiagnosed? Hypomagnesemia can be mistaken for cerebralitis, paraneoplastic syndromes, autoimmune disorders, meningitis, encephalitis, Wernicke's encephalopathy, neurodegenerative disorders, toxic conditions, and posterior reversible encephalopathy. The manifestations of hypomagnesemia include, in the peripheral nervous system, we can get carpopedal spasm, muscle cramps, muscle fasciculations due to axonal injury, and myopathy. That is, both the nervous, peripheral nerves and the muscles can be affected. In the central nervous system, it can cause a variety of clinical manifestations, including headache, mimicking migraine, chronic vertigo, downbeat nystagmus, periodic nystagmus, cerebellar ataxia with signal changes, it's called Hicks syndrome. If that is severe enough, it can cause obstruction, causing obstructive hypercephalus. Variety of movement disorders including chorea, athetosis, tremor, myoclonus, hemiparesis, depression, delirium, and seizure. Apart from this, systemic manifestations include a combination of hypokalemia and hypocalcemia that should prompt looking for hypomagnesemia. It can cause cardiac arrhythmias. In long term, it can cause hypertension, may accelerate atherosclerosis, and can look like chronic fatigue syndrome. Coming to Hicks, it is a distinctive syndrome of subacute ataxia with other features like seizures and encephalopathy. Characteristically, one sees downbeat nystagmus or periodic alternating nystagmus due to involvement of the vermis and nodules. Typical MRI findings are bilateral, very rarely unilateral, cerebellar hemisphere signal changes, bilateral nodular or vermian signal changes. Another clue is combination of hypokalemia plus hypocalcemia. This is the MRI of a patient reported by Cam et al. In Frontiers of Neurology, showing cerebellar signal changes in bilateral cerebellar hemispheres, which is presumed due to endothelial dysfunction and capillary leakage, blood-brain barrier. Coming to the causes of hypomagnesemia, the three most important causes are alcoholism, which can cause skeletal muscle magnesium depletion and also increased loss from the distal convoluted tubules, malabsorption syndromes including the gastrointestinal surgery, chronic use of proton pump inhibitors, which promote gastrointestinal magnesium wastage. This is how PPIs can cause hypomagnesemia. In the upper panel, you can see small intestine. Magnesium is absorbed in a paracellular manner. In the colon, It is transported by an active transporter called PRPM6 by 7. This is the picture showing the relation of luminal pH with solubility of magnesium. As the luminal pH increases, that means when it becomes more alkaline, the magnesium is changed from soluble to insoluble form, forming salts like magnesium chloride, magnesium phosphate, and so on. So PPS increase the pH, make magnesium insoluble, causing magnesium insoluble. In the colon also, with increased pH or in alkaline media, the transporter PRPM would transport magnesium becomes less effective, causing magnesium malabsorption. So coming to the investigation, apart from the magnesium levels, we have to check calcium, potassium and sodium levels, PTH levels. If you are suspecting genetic causes like Bartter syndrome or Gitelman syndrome, ABG is required. And 24-hour urinary magnesium more than 10 to 30 mg suggests renal losses rather than GI. Finally, how to treat? Intravenous magnesium is very rapidly effective. The dose is 50 milliequivalents, slow IV over 8 hours in emergency. With this, ataxia resolves rapidly if treated early. If the treatment is delayed, residual ataxia can persist. Oral magnesium maintenance therapy is required, preferably with sustained release preparation. The dose is 6 to 8 tablets per day in divided doses with monitoring of magnesium levels. In addition, we have to correct the calcium and potassium levels. And finally, elimination of cause of hypomagnesemia. Thank you.